Good afternoon, everybody. I know people are still trickling in, but I think I'm going to go ahead and introduce our speaker. I know he's got like a full jam-packed hour of content to give you, and so I don't want to take away any of his time. But my name is Jamie Johnson. I'm a pharmacist and a clinical toxicologist. I work as a medical science liaison with BTG Specialty Pharmaceuticals. That's the company that makes the anti-venom crofab. But that is not necessarily the topic of discussion today. So today we're going to hear kind of a state of the disease state address on envenomation by an authority on envenomation management and research. So we've got Dr. Charles Chuck Gerardo. He's a professor and chief in the Division of Emergency Medicine at Duke University School of Medicine. He graduated with honors from Stanford University with a Bachelor of Science in Biology before receiving his MD from the University of California, Davis. He went on to complete his residency training in emergency medicine at Loma Linda University Medical Center and completed a Master's of Health Sciences degree from the Duke University Clinical Research and Training Program. Since 2000, he's been an EM faculty member at Duke and has served in numerous educational, research, and administrative leadership roles. And his research focuses on the clinical effects of US and global snake envenomation. And you can find his work in JAMA, the Annals of Emergency Medicine, Academic Emergency Medicine, and Clinical Toxicology. I know that his research and the subsequent publications have changed how I take care of snakebite patients, like my approach to envenomation management. And I hope that you all find this lecture just as meaningful. If you do and you want to chat more with Dr. Gerardo, he has graciously volunteered an additional 30 minutes for questions after this session. So you can join us in the Zoom meeting or at the Zoom meeting. I think it's in the Zoom meeting, but the link for that meeting is in the chat. So you can hop over there after this session and talk with Dr. Gerardo, and I will lend the floor to him.
Hi, thanks for having me. When deciding whether I should give this talk from home or from my office, I was weighing whether I should worry about the barking dog versus the fact that my office is under the helipad. And right as Jamie is talking, the helicopter is landing. So I'm not sure if you guys could hear that or not, but I apologize in advance. But since you're all emergency physicians, it's something you're probably quite used to. I do need to disclose that this talk is funded by BTG Specialty Pharmaceuticals, and we're going to be talking mostly about snakebite research. And sorry, I need to admit that person so I can scroll down. As far as the objectives for this talk, I basically want to very quickly describe the current state of where we are both research and the clinical care. But this won't be a talk about how to manage snake bites. Really, I want to do that so that we can talk about what some of the current gaps in clinical care and research are, and then really spend the bulk of the time talking about potential research methods to really address this problem. That being said, this is because of time. This will be a pretty cursory review of some potential research methods we can use, but really my unstated objective is for everyone in the audience to kind of think about their own snakebite research and how they could apply some of this or have it spur ideas for them. So just a quick overview, talking about the US first, the incident of snakebite in the US, there's about 5 to maybe 10,000 bites a year. And most of those are venomous. And of those, the vast majority are pit vipers with a few coral snake bites and a few exotic snake bites as well. Of the pit vipers, the single most common envenomating species is the copperhead snake, which is the bulk of what I treat right now. And as you can see from the map across the US, the further south you go, the warmer the weather, the more likely snakes and humans are to come into contact with each other. The globally, the story is both similar and different. So There is about 2 million annual snake envenomations globally. It's about 100,000 deaths every year, leaving about 400,000 people that are estimated to be permanently disabled. There's not a clear understanding of transient disability or what proportion of those patients are eventually fully recovered, but are disabled for some period of time. And as you can see from the map, this primarily impacts the tropics and the subtropics, and specifically to our work in snakebite, that you can tell from the map that involves a lot of low and middle income countries are impacted by snakebite. And specifically within those countries, areas that are resource limited are the greatest, more greatly impacted by snakebite. Consequently, the World Health Organization designated snakebite, and they call it snakebite envenoming, which is not really a term we use in the US, but I may accidentally use it. But anyway, the WHO designated a neglected tropical disease in 2017, and then 2019 released a strategic plan for snakebite envenoming. Briefly, as everyone on this talk knows, antivenoms are the cornerstone of therapy. A brief review is they're really antibodies that are recovered from vertebrate animals, either horses or sheep. And the early antivenoms were just intact IgGs or the serum. The earliest were just the serum, but intact IgGs are pretty crude purification. So there was a lot of adverse reactions. So a lot of acute or immediate hypersensitivity reactions, as well as serum sickness. Modern antivenoms that we use today are very different. They're really cleaved IgGs, so antibody fragments, Fab or Fab2, and they're highly purified. So adverse reactions are not only less common, they're less severe. So these are pretty safe medications. They are smaller in size, so that's a kind of representing a Fab antivenom as opposed to a Fab2 antivenom. But because they're smaller, they may be cleared from the system where you still have some venom and you can get recurrence, which means you get some return of some of your symptoms after initially having the envenomation under control. That actually occurs with all antivenoms. It's just with the smaller antivenoms that we were able to really notice it and then look back and realize that this has been happening the whole time. I've listed 3 antivenoms, even though 2 are available, because some of the people in the audience may have used, as have I, the old Wyeth antivenom, which was a full IgG antibody antivenom, and we're familiar with all the adverse reactions. We take care of patients, we'd wring our hands as we're running in the antivenom and hoping that the treatment wasn't worse than the disease. The new antivenoms allowed us really to push down that threshold to treat, because the safety profile is so much better. And I just list on this table some of the big differences between the two. Just a short history, antivenoms have been around for more than 100 years. So in 1887, Sewall immunized pigeons with cottonmouth venom, and saw that impacted and was somewhat protective if they were given additional venom again. So in 1895, Calmette developed an anti-snake serum, which was actually used in humans after its development. Obviously, they did not perform any clinical trials. They just went straight to first in human. And then a few years after that, there's some Vital Brazil, which began to use mono and polyvalent antivenoms. And there was a big academic debate between the two on whether antivenoms were species specific, and there just wasn't the same sort of understanding of antibodies or the biology behind how antivenoms really worked back then, over 100 years ago. In the early to mid 20th century in the US, there was another antivenom available, and in parallel with that, there was also some improvement in the technology around antibody fragmentation. But it wasn't until 2000 that we began to have antibody fragment antivenoms that were available in the United States. And of course, to get those approved, there were clinical trials. It wasn't straight from pigeon to human back then. And so I just listed out the published clinical trials on US antivenom. And as you can see, there's this theme is there's not a lot of them, which is of course the highest level of evidence that we're able to obtain around clinical efficacy. So it's important to put the future the current and the future of snakebite research in the context of what is achievable. So the first one was, these are just the dates they were published, obviously not the dates that were conducted, but was the CRO-TAB trial. And that's not a misspelling. It's not supposed to be CRO-FAB. CRO-TAB stand for Therapeutic Antibodies, which was the company at the time. And that was just 11 patients enrolled. And then their pivotal trial, their phase 3 trial was 2 arms with different doses. So the CRO-TAB2. In 2013, there was a phase 2 FAB versus FAB2 with 12 patients, where the outcome was a quantitative serum venom level. So not these patient-reported outcomes that we're going to talk about later. And then in 2015 was the FAB versus FAB2 phase 3. It was a 3-arm trial. We're going to talk a little bit about 3-arm trials, but this is the largest clinical trial, had 121 patients. And then in 2017, we published the FAB anti-venom for copperhead versus placebo, which had 72 patients. And that's the only one that has 1 a placebo arm and 2 a patient-reported outcome. So each one of these trials is unique, and you can kind of see the evolution both in size and in refinement of the study design as you kind of go forward in time. So that's it. Five published studies. There's actually some other activity in the background that hasn't been published as well, but these are the 5 published ones. So the purpose of this slide is just to point something out, which is if you look at pre-hospital interventions and hospital interventions, many things have been tried without being well studied before they were tried. So very similar to going from pigeons into people. For anti-venom, there's a lot of things like prophylactic fasciotomy or electricity or cutting and sucking and all these things, which we now know are harmful, that had been tried. And that's what kind of happened with anti-venoms. They were used in humans before we really knew that from science that they were efficacious. It just so happens that they are efficacious. So now we have the evidence that they can be safely and effectively used in humans in a way that we didn't when they were initially used. So it didn't work for everything else, but it happened to work for anti-venoms. And hopefully we won't be making those kinds of decisions moving forward. So what are the current gaps in clinical care? And I'll cover the gaps in clinical care as well as in some of the research gaps. So pre-hospital care, obviously anti-venom is administered in a hospital. There's a potential for the development of bridge therapies for if you're in the wilderness and you're bitten, or if you're in a remote area or rural area, is there any bridge therapies to get you to definitive care with anti-venom? There's also a lot of work can be done around access to care, because these are time-dependent treatments and a time-dependent disease. There's not a clear understanding between obtaining and maintaining control and what the threshold for additional anti-venom is in clinical care. We know little to nothing about rehabilitation in this area. There's still some things that are important to know about safety. So the 2 US available antivirals are purified differently, and is there benefit from one over the other, and from a clinical sense, not just from a theoretical or a biologic standpoint, but does it matter clinically? And also, I think there's a lot of work to be done on how we consistently measure harms in these trials in a way that's appropriate and specific to antivenoms. And then lastly, we may gain some research knowledge, but translating the existing evidence is very difficult. There's a big time delay, and how can we improve? That remains a gap. As far as research gap, we know very little about how to prognosticate in this disease. We also don't completely understand the functional impacts. So our functional outcomes, which are important not only for clinical trials, but also for cost effectiveness. It's difficult to tell if something is worth the cost if we're not even certain how effective or what sort of disability the snake bite is causing, and then how that is impacted by any given therapy that we want to assess cost effectiveness. So functional impact and outcomes are a really understudied area. Of course, there's a lot of, if you look at the global picture, there's a lot of public health work that needs to be done so we can treat more people more quickly or quicker. And then there's also these new therapeutic targets and novel agents which are being developed, like small molecule inhibitors. One of the interesting thing on therapies is anti-venom is a treatment that's focused on the venom. so that it binds the venom and inactivates it, which has some benefits because you're going to the source of the problem, source control. The disadvantage is if the venom has already initiated either an inflammatory cascade or some other biologic process, the anti-venom won't necessarily put the genie back in the bottle. So it has both an advantage and a disadvantage. Some of the new therapeutic targets are focused on what we would call host response. So the things that happen once the venom has initiated the pathology. So that's kind of an interesting wrinkle on how we approach new therapeutics. So this is a simplified research paradigm. You might say that seems awfully busy for a simplified research paradigm, but the reason I say it's simplified is it just creates a mental structure or a visual structure in our mind of how we can apply some different research methodologies. And our group focuses on inflammation and thrombosis as it leads to diagnostic, prognostics, and therapeutics, so that we kind of arrive at an individual patient outcome. And then also the work taking individual patient outcomes to impact population. So it works for us. Your group's diagram would look very different. You know, there's no neurotoxicity here. We're not talking about the kidney in any of this yet. So there's a lot of ways that if we looked at snakebite comprehensively, that there'd be a pretty tangled web of research methodologies and overlap. But this simplifies it somewhat. And I'm going to use it for this talk just to kind of create structure to walk us through both where we are and some potential areas we could go. And I won't cover, obviously, all of these different methodologies. So currently, there's been a lot of work done by toxinologists on mechanisms, especially in the area of proteomics, so venomic and anti-venomic work. And there's a lot of data and science that's been done in that area that's really informative. And yesterday, we heard Keith give a talk on that. There's also been some clinical trials, as we described. There is a lot in all of toxicology. There's a lot of cohort studies, retrospective cohorts in particular, but also case reports. And then there's times when that's considered high science when we're trying to figure out this disease. There is some surveillance and some existing databases which are often used. And then there's been some work into kind of understanding the performance of existing labs and physical exam and whatnot. We're going to walk through 3 or so different areas, and we're going to start with clinical studies. So the clinical trials, yes, but I want to focus on 2 things. One is alternative trial designs to address some of the challenges we have, as well as patient-reported outcomes and their psychometrics, so we could better inform cohort studies and clinical trials. So the clinical trials, what are the challenges? One is snakebite's a really heterogeneous disease. You could argue it's not one disease at all, not only varied by species, but also by clinical presentation. So that becomes really challenging. Also, enrollment is difficult. So sample size of the trials, as you saw from the prior slide, are really small. There's a big risk of loss to follow-up, although we've been able to mitigate some of that. And then the clinical site research infrastructure also creates a challenge. So the areas that see a lot of snake bites or have a snakebite expert may not have a lot of research infrastructure. I always say, if you're looking for a site for a clinical trial in snakebite, you need 1, a place that sees a lot of snake bites, and 2, someone who performed well on their last sepsis clinical trial or some other non-snakebite related research. Those 2 things have to be married. Otherwise, what you get is 1 more snakebite expert with no patients to enroll. Also, we have real challenges in clinical trials around outcome measures. There is not consistency. They're not comprehensive across species, of course, but they're also not even comprehensive within species. Most are not very flexible to handle different ages and different baseline functionality of the patients. We out of necessity have used a lot of surrogate markers, and most of these outcome measures are not patient-centered. And lastly, they're psychometric, so their validity, their reliability, and clinical significance of differences have been assessed in the vast majority of outcome measures. And this is actually an example of some of the enrollment challenges that we talked about. This is from the Copperhead CroFab trial. So, we randomized 76 patients, of which 74 got treatment. Just over 9% were lost to follow-up, although we do have some data, and they all were included in the analysis. This was a 2-year study, multiple centers, and it's only 74 patients. So hopefully that gives you an indication of how difficult enrollment in these RCTs is in snakebite. So what are some of the solutions, some of the research solutions? One is trial design. So if we can design trials that are species agnostic when appropriate, I guess you guys are hearing the helicopter. It's the military one, so it's the loudest. But anyway, so species agnostic trials are helpful. And that actually mirrors clinical care. So often you don't know the species or don't have the snake when they come in. So if you're performing a clinical trial, it's good if it mirrors what the decisions you're actually going to have to make. Deciding whether it's a copperhead or a rattlesnake or whatnot is really difficult in clinical practice. The other thing we can do is simply limit primary outcome comparisons. I do think that the 3-arm trials can be a little overly ambitious, which creates a problem in the analysis when you're making multiple comparisons and you're losing some of your power because you're making multiple comparisons. I think when we design these studies in the future, we should really have a simple, focused, single primary outcome and try to get information regarding some of these other questions through secondary outcomes, recognizing the limitations of that, but be really willing to subordinate some of the secondary questions to the primary questions and just have a 2-arm trial when possible, which will decrease the sample size that's needed. There's some additional work around stratified randomization because the trials are small, to make sure the groups are equal. And then in the copperhead trial, we used some statistical methods to deal with residual imbalance that may have existed because, as I said, these studies are small. You can always do 2-to-1 randomization, which for certain trials like one with placebo arm may increase enrollment and also increases your sample size, but that can be offset by the increased enrollment. But so those are the easy things, but how about just the design in general? So I think we need to consider increasing the use of alternative trial designs. Here is a response adaptive randomization. And just as a reminder, this sort of randomization or trial design is play the winner versus drop the loser. So let's say you have 2 therapies, one of your therapies is green circle. So you take, let's say the patient receives green circle and has a good outcome, then the next patient is randomized with the increased likelihood of being randomized to green circle treatment. Conversely, let's say they have orange circle treatment and they have a bad outcome, well, the next patient has decreased likelihood of receiving orange circle treatment. And so through that, you can get a more efficient trial as the patients are more likely to fall in the efficacious bucket over time. So that's one example. There's others. There's Bayesian trial designs, which are really interesting. Normally when we do a single clinical trial, we look at it by itself and then try to place those results in the context of the existing literature. With the Bayesian trial designs, we're able to incorporate existing literature into the priors, and so that we can get this post-study probabilities of efficacy. So those are really interesting as well. I don't have a slide specific to those, but that's just another example of an alternative trial design that we could deploy. So I want to spend, this will probably be the deepest dive we take on any one subject, and this is around outcome assessment. So when we look at outcome assessment for clinical trials, our primary endpoints, just a reminder, you can classify outcomes into 4 different categories. So observer reported outcomes, and these are things like what is the platelet count? What is the fibrinogen? Some of these things that your CRC can put into REDCap. And then there's also clinician reported outcomes that have been used, often around the extent of swelling. That's an example of a clinician reported outcome. They've also used basically clinician's gestalt. So either the investigator or the clinician's impression of whether the patient's getting better, the same, or worse, those types of things. So those are clinician reported outcomes. There's performance outcome measures. In snakebite, those tend to be things like strength or dexterity. Examples is measured by grip strength or walking speed. And those give us some information around function, but I want to point out how different they are directly from patient-centered outcomes. So, for example, let's say someone has a snake bite to the hand and has returned to 95% of their grip strength as compared to what it was like before they were envenomated. Well, we don't, that 95%, you may be able to see a difference and it may be statistically significant, but the question is whether it matters clinically, meaning, does it impact their ability to open up a door, or like grab a door handle and open up the door or not? It's difficult to say. Or in the case of some of our snake bite patients, probably a better functionality measure was, does that decrease in grip strength allow them to open up the mason jar of moonshine? So you get the idea of how grip strength is reflective, but not identical to functionality. And then that leads us to the last group. So patient-reported outcomes, which are measures of functionality. There's many different ones that have been invalidated and accepted and used in other diseases. And as emergency physicians, we're always talking about, every journal club you talk about, but did it matter to the patient? So this patient-centeredness of patient-reported outcomes is one of the reasons that we focus so much on them. And if you look at snakebite, remember that there are acute phase outcome measures as well as outcome measures during recovery. And the relationship between those two is not well understood. On the left is the snakebite severity score, which is made up of multiple clinician-reported outcome for local wound, observer-reported outcome for hematologic scoring system. What is the relationship between that and something like recovery? And this is just one recovery measure of opioid use during recovery from the Copperhead trial. That basically the green line is the anti-venom and the gray line is placebo. And it was on the y-axis, the proportion of subjects using opioids over time. That's an example of looking at impact or efficacy during recovery. And so the relationship between acute phase envenomation and recovery are important in an area that's ripe for additional research. We wanted to know what's actually been used. So we've performed a systematic review and have presented the results in abstract form. Hopefully the manuscript will be submitted soon. But we use the standard PRISMA approach for reporting systematic reviews and meta-analyses. And we wanted to catalog all the prospective human snakebite studies. And since this was a comprehensive approach, as opposed to a very focused, simple clinical question, we wanted to catalog what exists. We had 199 final articles. As you can see, most of them aren't clinical trials, but certainly some are worldwide. And those are increasing in the amount. So as the field matures, we're getting more of these. And this is kind of where they're from. I think what's important here is a lot of these areas don't have clinical trials. A lot of the trials were done in the US, and that's those 5 studies we talked about. But a lot of these low and middle income countries in the tropics and subtropics haven't really had prospective snakebite studies and much less clinical trials. So there's a real deficit there. And these are some of the different outcome measures. Labs and biomarkers were very common. So these surrogate markers, which, think about it, what's the difference between 75,000 platelets versus 100,000 platelets in a patient? It's difficult to translate that into something that's clinically meaningful. Venom level, once again, has been measured, but there's few studies that have any patient-centered outcomes. So our conclusions are that, one, we need to do this research in low and middle income countries where the bulk of the impact is, and it'd be good to develop and use patient-centered outcomes, which have been scarce. And then, of course, correlating the existing surrogates with these patient-centered outcomes, that work remains to be done as well. That being said, we can talk all we want about patient-reported outcomes and how they're patient-centered, but I think as a field, as a collective, there's some work to be done within ourselves to both accepting these and understanding them and gaining familiarity with them. Because I will tell you, there is not a lot of familiarity with them. On the clinician side, and you can translate clinician into reviewer, into other investigator, other snakebite investigator, whatever you want. But from our side, I just put a quote of a letter to the editor regarding the PSFS, which I'll go into in a second, which is one of their patient-reported outcome measures we use. And they felt that it was ambiguous and that it was self-reported. And that's actually kind of the whole point, is that it's self-reported, not that it's ambiguous. And they preferred things like strength and dexterity. So these performance outcome as opposed to patient-reported outcomes. And you can understand that, right? They seem more objective, but strength and dexterity only matters in as much as it impacts the patient, as I described with the 95% strength example. And it isn't just clinicians, and it's not just researchers, it's regulatory bodies as well. If you look at any of the trials and look at clinicaltrials.gov, none of the trials that have led to the pivotal trials or even the phase 2 trials or any label changes have come from the PROs. They've really been come from these other conglomerate of other outcomes. So I think that there's work to be done in the understanding of these PROs by both clinicians as well as regulatory bodies, because we can't really have it both ways. We can't say we care about the patients, but the thing that measures what is impactful to patients, we're not willing to accept. So that's kind of outcomes. I will tell you some additional work in the outcomes area that this group can consider is existing knowledge gaps. So we know something about permanent disability, but there's a lot we don't know about the impact of transient or temporary disability. We know almost nothing about behavioral health and psychological impact of snakebite. So there are some groups internationally that are beginning to scratch the surface of that topic. We know something about mobility, but other functional domains, there's some work to be done. And we focus a lot on return to work, but the social impact and the other impacts of snakebite remain to be studied. So those are areas that are ripe for study. I want to use this one tool, this one patient reported outcome that we have used to explain kind of what we're doing in hopes that will spur some thoughts on your end for potential studies you could do. So the patient, just a quick review, the patient-specific functional scale is this patient-reported outcome where you have the patient choose 3 different activities that they were able to do that they're now not able to do. And they rate that, their ability to do it, on a scale of 0 to 10, 0 being I can't do it, and 10, it's totally normal. And the nice thing about this is as they recover to whatever their post-envenomation permanent state will be, you can see the change over time. And what I really like about this tool is it's flexible because they choose the activity. Someone who it's a big deal to walk down to get their mail can choose walking as the activity they're not able to do. Yet it's someone who runs a marathon can put that as their important activity that they're not able to do. So their baseline functioning is already incorporated into the activities that they are choosing. So, unlike some of the other patient-reported outcomes that ask questions like, are you able to walk up 1 flight of stairs? Or, how many steps can are you to take X number of steps? These are much more flexible and allows them to put into activities that best reflect the impact of the envenomation on them. So that's the patient-specific functional scale. We had 2 prospective studies, one a trial, one an observational study that had data on over 90 patients that filled out. So 3 activities for over 90 patients. So we had a bunch of data on these activities that were chosen. So we applied an existing rubric, the WHO International Classification of Function, to these activities to try and describe what was the impact of, starting with describing what is the impact of snakebite on patients. So the way this kind of theoretical construct works is you start with a health condition. In this case, it's snakebite envenoming of the lower extremity. That for this one patient is one of their activities. That, of course, impacts your bodies and function. So tissue injury, pain, swelling, mobility, that kind of stuff. And then the activity is walking. And in this specific case, it was walking in school. So this participation element of the activity. And those are impacted by environmental factors like, do they have assist devices in the school? Is there support from the academic institution? As well as personal factors like, what is their age? What are the consequences or the concerns about missing school for the age group and for that patient? And so that's kind of this theoretical construct of the activity And then you take that, we took the components of the activities and the participation, and those are divided into standard domains or chapters. So mobility is one of them, that almost all people were impacted by their snake bite. But there were other domains as well, like interpersonal relationships, other general tasks, and communication, domestic life, self-care. You get the idea. And I've highlighted 3 activities just to give you an idea of the information you can get from this PSFS and these snakebite studies. So one of the patients said opening medicine bottles. So their snakebite impacted that. So that's important for a number of reasons. One is it shows you it kind of impact on a patient that we haven't really thought of, like it's important that they take their antihypertensives or their antipsychotics or whatever it is, and that the snakebite impacted their ability to do that in a way that it may not impact for someone who was healthy or not on medication. The other one I found really interesting was praying. I can tell you that hadn't even crossed my mind that a snake bite was going to impact the ability of someone to worship in the way that they wanted to. But because that was important to them and they chose it as an activity, we were able to measure how they could return to function on this essential element of their life. And that fell under religion and spirituality, under the community, social, and civic life. And then the last one I want to point out was playing ball with son. Obviously, that's an important activity, and it can be captured under interpersonal interactions and relationship. It actually falls into multiple domains, so also community and civic life, as well as mobility. So you can double code any of these activities, or triple R as many as the domains as they fall into, get a more robust understanding of how snakebite is impacting patients. So I kind of walked you through this to show you, oh, these are some of the kind of things we can do in the snakebite research area, but also to point out how impactful snakebite is in something like measuring the platelet, your platelets doesn't capture any of this information. Even something like measuring grip strength or walking speed does not capture these kinds of activities. So these patient-reported outcomes, especially those that are flexible, have the opportunity to let us ask many questions. Hopefully, in reviewing this, you've thought of questions you would like to ask of using these patient-reported outcomes. That was kind of step one. What we're doing now is working on what areas were most impacted, what domains were most impacted, and which were most responsive to treatment. So to finish up with outcome assessments or endpoints, I think ideally we need to get to an accepted definition of what are the core metrics, so a minimum data set. And fortunately, there is a group that's working on that. Once that's developed, I think we can get to assess the psychometrics of that minimal data set. Hopefully this will be generalizable. The holy grail would be generalizable across snake, genera, and species. And then once we get there and they're validated, I think we can move into standardization, harmonization of the data globally. If we do that and everyone's measuring the same sort of minimum outcome measures, we're going to be able to ask all sorts of questions of different research data sets that we currently just are not able to compare or ask questions of. So I think that's what the future holds in that area. So let's pivot from that kind of work on outcome measures and trial design to going from the individual to the population. There's a lot of different research methodologies we can use in this area. I'm going to talk a little bit about implementation science, although we're doing some of the other work as well. Think about it, implementation science with regards to the evaluation of treatment algorithms. Currently, there are consensus algorithms, which are really an improvement, but they have not been regularly assessed with regards to their performance, and particularly certain elements of their performance. So I just threw up some questions that I have that we could ask through implementation science, which is like, what is the relation between gaining and maintaining control in the final functional recovery when you apply it within these algorithms? Or if an element of the algorithm is, well, you're going to watch a watchful waiting for progression, well, what are the potential benefits and the potential harms of that strategy, and how does that play out in the real world? And then you can also ask questions around what is the threshold, should the threshold for unscheduled treatment be, and what yields better outcomes? So that's an example how we can use implementation science. The way our group is proposing to use it is to really understand gaps in access to care. So we know that snake bite's a time-dependent disease. And so how do we get anti-venom and other effective therapies for that matter to patients in a timely fashion. I think this group can see the immediate benefits for either rural emergency departments or for wilderness medicine when you can't get access to anti-venom. Our focus on our proposal is low and middle income countries. Specifically, we're starting in Brazil. Brazil has a nationalized healthcare system and as well as a nationalized data set of health, which allows us to ask a lot of questions that we could not otherwise ask. Snake bites, we know from prior work, occur primarily in rural areas, so like the Amazon, which is demonstrated in that GIS study of Brazil. But importantly, morbidity and mortality are disproportionate in these more rural areas. So not only are there more snake bites, but they do worse in the Amazon than they would in a large city like Sao Paulo. And then they have these community health centers throughout the country, and in the Amazon they have access to care in these community health centers, but anti-venom currently is not available in most of them. So we have partnered, Duke Emergency Medicine has partnered with the Tropical Medicine Foundation in Manaus, as well as the Butantan Institute, which is the producer of anti-venom, to propose a 3-aim study. And that is, aim 1 is to develop decentralized anti-venom distribution models. So we'll optimize them by geographic location and travel time to CHCs. To the right is an example of one of the techniques we're going to use, which is dosimetric mapping, which you take existing satellite imagery to determine where the human structures are, so you can find out right where the people are, which matters because of travel times, in a way that just attributing them evenly across a municipality is not as effective, and it's not as a precise modeling. And so we'll do some machine learning GAI model development. Aim 2 is around looking at economic evaluation of these various proposed models, and we'll take the standard techniques that exist in other areas, so societal perspectives and healthcare system perspectives that are commonly used in healthcare economics. And then the third aim is to develop a culturally relevant snakebite care package. So not just the anti-venom distribution, but all the things, the education, the refrigeration, all the things that would be needed to deploy anti-venom via the model developed in aim 1. If that's effective, then we can go on to a comprehensive implementation study using the consolidated framework for implementation research. So that is just one example or one proposal of how we can use implementation science in snakebite research, married with what we commonly do in other global health work for other diseases. So that was kind of going, we started with the clinical trials that we're all familiar with, pushing out towards populations. I kind of want to briefly go in the other direction and talk about some of the basic science, or particularly the translational work and some of the systems biology and advanced modeling that we could do combined with some of this translational research. And so, there's novel therapeutics development. There's venom, things focused on the venom and things focused on the host response, as I had stated before. For example, small molecules, an interesting example is verasplidib, which is a phospholipase A2 inhibitor that has pretty robust clinical or preclinical data. And so now it's time to move into the clinical applications, but all that is derived from this kind of preclinical work that has been done and is ripe for study in either other molecules or in this molecule. Additionally, in the translational science space, people are starting to look more at the immunologic response. So this is a study out of the people that we actually partner with in Brazil, where they looked at soluble inflammatory markers and the networks based on outcomes. So if you look at the red dots, those are all cytokines. I know it's a little hard to read. The green dots are chemokines, and then the orange circles are complement. And they're looking at the relationship in the network predictive of healthy donors versus mild outcomes versus severe outcomes. And there's additional advanced modeling techniques and systems biology approaches that can be used. What we've done in a grant, we have a sub-study out of a larger DoD grant that looks at taking clinical markers and immunologic biomarkers and predicting recovery. And this is just a Bayesian belief network of some of the preliminary data. It's not worth going into the details since it's preliminary, but you get the idea of how we can really convert from this reductionist approach to a more systems biology approach in prognosticating or in finding therapeutic targets. The last area around translational science I want to talk about is around coagulation and thrombosis. You know, Stephen Seifert did some great work around evaluating the quantitative measures and their ability to predict late bleeding, but the work is just starting around function. So some of the thromboelastography work is beginning to be done, but a lot of untapped area around platelet aggregation, as well as novel biomarkers like platelet serotonin or p-selectin or platelet factor 4, these other areas. Of course, complement we've talked about before, that's going to be important in the kind of thromboinflammatory connection. And we'd really like to know what happens with this pathology, what's the natural history over time, and how that natural history is impacted by either anti-venom or other novel therapeutics that will be developed. So there's plenty of challenges. We talked about some cool stuff, but it was really just a whirlwind tour of some possibilities that barely kind of scratched the surface of the things that we could do in this area. I think some of the big challenges are funding. A lot of this work, which is why we have a lot of case reports and retrospective chart reviews, has been unfunded. And you know, that's still important work so long as it's conducted with scientific rigor. But industry has funded a fair amount of that. And I think our expectation of what industry is willing to fund needs to be a pretty sober assessment. And so we also need to think about foundations. With the WHO's strategy for snakebite and venoming, the Wellcome Trust has put a lot of money into this issue, and I think that is one potential area to get funding. And then there are some potential federal funds, and we have to be creative here. So DoD, I think, is fairly obvious. But within the NIH, it depends. If you have an interest in coagulation, then maybe NHLBI versus our proposal to Fogarty and those kinds of other options. Another challenge is our data sources. Our current databases have a lot of issue with spectrum bias and selection bias. Not all patients are going into some of these more commonly used databases. So we're always scratching our head exactly what the results mean. And same thing with retrospective cohorts. So I think this work in outcome measures and consistently using that across studies will be of value. I think there's also challenges around there's not existing clinical trial network specific to snakebite. And I've already talked about the issues and site selection. And then I think lastly, there's this issue around the audience, be that the funders, other clinicians, other researchers, and that if we're going to really move this field forward, we need to incorporate new and innovative and novel research techniques. And as we do that, it will become uncomfortable for people who are used to seeing the same approaches. So I think real change will be through the Medici effect. We're going to be on the limits of what we typically do and pushing that out to where it intersects with some other discipline or specialty. And at those edges is where we're going to create real innovation. So there's a need for both this like deep dive into your specific area, but also cross-cutting research techniques that we're familiar with in other areas of research like sepsis or cardiovascular disease or clotting or neurologic diseases as well. So I think my conclusion is the days of inoculating pigeons is long gone, that's not how we're going to get to new therapies and improve care. And that we need to acknowledge that doing research in this area is really challenging because it's an orphan disease. And we should soberly assess the limitations of what we've done so far, yet kind of have that spur us to create new knowledge and leverage all the tools that are really available within the research realm to answer some of these questions. So I say we leverage all acceptable, feasible, and available research methodologies to try and discover the truth in what is otherwise a pretty challenging area of research. So that last slide is a little bit of my soapbox. So I'll give everyone a moment as I step down from my soapbox to see if they have any questions, and you can either unmute and ask, or you can put them in the chat, and I can see my chat pretty well, or Jamie can also look at it to make sure I'm not missing anything. I also recognize that, you know, on these Zooms, always asking of questions isn't always comfortable. So I'm going to be available, and Jamie will tell you about that afterwards if you want to ask questions in a smaller group. I'm fine with that as well. So I'll give it a moment.
While you guys are formulating questions, take a peek at the chat. You'll find a Zoom link with the password and everything it should be at the beginning of your chat feed, so you guys can join us here in a couple of minutes, and we can talk in a smaller group about the future of snakebite management. So,
well, with that, I'm going to write down the passcode so I don't forget it. Jamie, I'll get in trouble. Since it doesn't look like we have any more questions, why don't I let everyone who's interested go to the new Zoom link, and I'll be happy to discuss some possibilities. And I'd be interested to hear anyone else's ideas they have on other methodologies that we haven't used. So Alex asked me, what do you think about training the next generation of snakebite researchers? I think a lot of things about that. I think as an emergency physicians, we're going to play an important role, but we also need to really be less, not only specialty focused, but discipline focused. So I think the best research is going to come, and the best training of researchers is going to come from really diverse mentorship groups, diverse research groups. So partnering with people, with hematologists, for example, but also other disciplines. So data scientists, you know, you saw the work that we're proposing to do using GIS and geo artificial intelligence. So that kind of work can be done, as well as close partnership in training people in the basic and translational sciences to do some of this toxinology work. I think the more we communicate, the more we collaborate, the more we'll have ideas of ways to approach what are existing challenging clinical questions, and putting trainees and so budding researchers into that environment. They'll come up with a lot of ideas that we won't think of on our own. Bill Toon has a question. Since it's a time-sensitive treatment, what role should EMS have with treatment? That's a great question. And I think we can push that. One is a really important role is getting them to what is currently definitive care, which is anti-venom treatment. But I'm hopeful as we begin to develop these novel therapeutics, that some of them will be appropriate for pre-hospital delivery, be either in pill form or sublingual form, or something that can be delivered before they get to the hospital. Should you really bring a dead snake to the hospital? No, don't bring. Well, and let me rephrase that. I want to see it. I want to get a picture of it. I want to prove that it was that snake if we do a case report. But no, don't do that, because I don't want anyone else to get bit. We've all bitten. We've seen plenty of patients who are bitten by the severed head, and we've actually had some really bad outcomes. And there's also in the literature, there's some deaths and other bad outcomes from being bitten by the dead snake. So don't bring the dead snake. Yeah, picture. Yeah, exactly. I'm down with taking a picture from a safe distance. That's really helpful. Any other questions? If not, I will see a handful of you over on the at the next Zoom. Thank you, and thanks for. I hope you have a great conference. I know I really enjoyed it so far.